Welcome to Pulse and Pressors, where critical care gets crystal clear. Today, we're focusing on one of the most easily missed infarcts, the lateral STEMI. The lateral wall of the left ventricle sits between the anterior and posterior territories. It's primarily supplied by the left circumflex artery, but sometimes by a diagonal branch of the LAD. Because this territory is small and electrocardiographically subtle, lateral infarcts are often underdiagnosed. On ECG, look for ST elevation in leads 1, AVL, V5, and V6. High lateral involvement shows in 1 and AVL, low lateral in V5 to V6. If you see reciprocal ST depression in the inferior leads, that's your mirror clue that the lateral wall is injured. One of the most important leads here is AVL. A small ST bump in AVL can be the only visible sign of a significant infarct. Don't dismiss it. Pitfalls abound, small elevations brushed off as nonspecific, underestimating clinical symptoms, and failing to consider contiguous lead patterns. These misses delay reperfusion and worsen outcomes. Culprit vessels vary. Left circumflex occlusion produces elevation in 1, AVL, V5 to V6, with reciprocal changes inferiorly or posteriorly. A diagonal branch occlusion affects mainly 1, and AVL posterior extension is common, creating depression in V1 to V3. To confirm the diagnosis, echocardiography shows lateral wall hypokinesis or akinesis. Troponins behave like any STEMI pattern, and coronary angiography identifies the culprit artery. Management is the same urgency as any other STEMI. Activate the Cath lab for PCI within 90 minutes. If unavailable, administer Fibrinolytics. Give aspirin and a P2Y12 inhibitor immediately. Start heparin and treat pain and ischemia with nitrates and morphine as tolerated. Once stable, add a beta blocker and an ACE inhibitor to reduce remodeling. In critical care, focus on hemodynamics. These patients may have impaired left ventricular function and become preload sensitive. Avoid overdiuresis or excessive nitrates in hypotension support with dobutamine or milrinone if cardiac output drops, and monitor closely for VTAC or VFib during reperfusion. After reperfusion, expect transient arrhythmias such as accelerated idioventricular rhythm, often a good prognostic sign of reperfusion. Repeat the ECG to ensure ST segment resolution and reassess LV function with echocardiography. Continue dual antiplatelet therapy, initiate high-dose statin therapy, and involve cardiac rehab early. Remember special presentations, posterolateral infarcts show depression in V1 to V3. Isolated AVL elevation may be your only clue. Elderly and female patients often present atypically, with dyspnea, fatigue, or minimal chest discomfort. Take-home summary: recognize elevation in 1, AVL, V5, and V6 with reciprocal inferior depression. Culprit artery, left circumflex or diagonal. Treat with immediate reperfusion. Monitor for LV dysfunction and arrhythmias. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.